Welcome to Navicent Knows Health. I'm Cindy Busby and I'm here today with Dr. Jessica Hutchins. She's a board-certified pediatric endocrinologist, and today we're going to talk about her practice here in Central Georgia. Dr. Hutchins, thanks so much for being with me.
My pleasure. Thank you for having me.
Could you let the audience know a little bit about what a pediatric endocrinologist does?
For sure. So most people probably may or may not know that one of the main things that pediatric endocrinologist treats is type 1 diabetes in children. Also, unfortunately, nowadays we actually are also seeing type 2 diabetes in children. With a rise in the obesity epidemic, we are seeing more children diagnosed with type 2 diabetes. But that isn't the only thing that we treat. So most common, probably after that, is thyroid disorders. So kids that have hypo or underactive thyroid, or hyper or overactive thyroid. Growth disorders, so kids that have growth hormone deficiency or issues with like short stature. Puberty disorders, so kids that have either a delay in their puberty or early or precocious puberty. Kids that have pituitary disorders, so the pituitary gland is a gland in our brain that actually produces many hormones that control our thyroid, our adrenal glands, which affect our cortisol levels. They also affect our puberty hormones. We also cover adrenal disorders, so kids that have issues with not making enough cortisol. So we treat those children. In addition to the parathyroid glands, so these are little bitty glands right behind our thyroid gland that controls our calcium. So calcium and bone metabolism.
What are some common symptoms that a parent might see in their child? They go to their pediatrician and then they get referred to you, outside of diabetes.
Yes, so for diabetes, I'll mention that just really quick because that's very important. So for diabetes, an increase in thirst, increase in urination, weight loss, and more fatigue or tired, vomiting if they get really sick. So that would be the symptoms of type 1 or type 2 diabetes, honestly. For thyroid disorders, like an underactive thyroid, oftentimes you may just see just extreme fatigue, constipation, like trouble going to the bathroom, oftentimes really dry skin or hair loss. And so, and what the pediatrician may notice is actually poor growth. So they're just not growing on the growth chart. And so sometimes the pediatrician may notice that. Or a goiter on their neck. So they may notice that their thyroid gland, which is in your neck, starts to enlarge. And so that can be a sign sometimes of either hyper or hypoactive thyroid glands.
When it comes to selecting a specialty, why was it that you were attracted to pediatric endocrinology?
I knew I wanted to be a pediatrician when I was 9 years old. I loved my pediatrician when I was a kid. I would tell my mom, I want to be a pediatrician like Dr. G. That was my pediatrician. I actually initially wanted to be a pediatric cancer doctor because my grandma had breast cancer when I was young. And so that's something that hit close to home. And then when I was in college, undergrad, I ended up getting a chance to do some research with patients that had type 2 diabetes and heart disease in the adult population. So I got exposure to diabetes, and that was kind of my first exposure to that. I didn't have it really in my family before that, or didn't really know anybody with diabetes. And then I got a job as a medical assistant in an endocrinology office, an adult endocrine office, in between medical school and my undergrad. And that's where I really got my firsthand exposure. And I was working with diabetic patients in this office, and endocrine disorders too, but mostly diabetic patients. And I was getting able to teach the patients and really learning from the doctor and nurse practitioners that I worked with in that office. And once I started medical school here at Mercer and starting to learn about the endocrine system and all these different feedback mechanisms, I was kind of just excited about it and just I think this is a really cool field that I want to go into. So luckily I actually still get to work with a lot of our oncology kids because again, kids that have brain tumors, sometimes they can develop pituitary disorders after. And sometimes kids that are undergoing chemotherapy, they have to get high dose steroids, and oftentimes will develop diabetes from the steroids. So you can get steroid induced diabetes on top of developing type 1 or type 2 diabetes.
What are some of the ways that children living with diabetes are being treated today?
Yes, so every child with any child or adult living with type 1 diabetes, the only treatment is insulin, because the problem with type 1 diabetes is that the pancreas is not able to produce insulin. And so in that case, the only treatment is giving insulin. So the normal method would just be using either a pen needle, a pen device, or an insulin syringe and vial to give the injections. And then obviously checking their blood sugars multiple times a day. Nowadays, the technology has been increasing rapidly, and a lot of kids are wearing insulin pumps. And so with the insulin pump, they have the insulin inside the pump, and they have either a tube or the pump is just connected onto them. and this is giving insulin to them all day. So instead of injecting themselves 4, 5, 6 times a day every time they eat, the pump is just always connected to them. And then they also have now continuous glucose monitors. So instead of checking your blood sugar with a meter multiple times a day, they have sensors they can wear that most of the time can change them every 10 to 14 days. And so instead of checking yourself 6, 7, 8, 9, 10 times a day on these really young kids now that we're having diagnosed with type 1 diabetes, they can often now check them, like only have to change that every 10 to 14 days. And these little continuous glucose monitors are actually giving them a blood sugar every 5 minutes. The technology has greatly improved, and a lot of these pumps and sensors are now actually talking to each other and creating what were like closed loop systems where the sensor and the pump talk to each other and help modulate the blood sugar.
If a parent who's watching today recognizes any of those symptoms, maybe just has had diabetes in their family and they think that their child might have some of these symptoms, what's the best way that they get to your office?
First thing, if they have not been diagnosed, first thing, just go talk to your pediatrician. So in the pediatrician's office, either you can just check a simple little finger stick, check their blood sugar, or even checking the urine. So when your blood sugar is high, your kidneys start filtering that out and you spill urine, glucose in your urine. And so even just, urine sample or a blood sugar finger stick can give you just that perfect check to see, is my child diabetic?
Can you tell our audience, what is the measurement A1C? We hear that a lot of times when treating diabetes.
The hemoglobin A1C is actually a 3-month average of the blood sugars. And so whereas just a regular glucose check is just at that point in time, but a A1C gives you a 3-month average blood sugar. So for the physicians, it allows kind of in between our visits to kind of let us know a general idea how the patient's been doing with their diabetes management. So even for a new onset diabetic, when we check that, that gives us a general idea of how high their blood sugars have been running. And so the A1C, it comes in a percentage. And so 6.5% or higher is considered in the diabetic range.
Well, thank you so much for telling us more about your practice.
Yeah, my pleasure, it's been great.
Thank you. And if you'd like to know more about Dr. Hutchins and her practice, please visit us at navicentnosehealth.org.
Thank you.